Hello everyone, welcome to Macleods Medlive Indian Perspective Expert Opinion. We are at CSICON 2019 New Delhi. I am Dr. Rahul Kotwal from medical team of Macleods Pharmaceuticals. Today we have a panel discussion on acute coronary syndrome. We have Dr. Ramesh Daggubati with us, who is a professor of medicine, West Virginia University, and SCAI International Committee co-chairman. And we also have Dr. Dhiman Kahali with us, who is senior consultant interventional cardiologist at BM Birla Heart Research Center and also chairman NIC Cardiological Society of India. So sir, basically starting with acute coronary syndrome, so how is the approach abroad versus India? So your opinion, sir.
So, I think acute coronary syndrome comprises of unstable angina, ST elevation MI and non-ST elevation MI.
Right.
And obviously in the United States there's a big impact on door to balloon times by having emergency medical services, even administering antiplatelet therapies to the patients, or in some scenarios in thrombolytics as well, and bringing them to the hospital, closest hospital, and then be treated whether with the primary PCI or actually following the thrombolytics. If they don't reperfuse, they get percutaneous coronary intervention. That said, we try to load all the patients in the emergency room with aspirin as well as with antiplatelet agent. In some hospitals it might be clopidogrel, but in other hospitals it's a ticagrelor.
Right. So, sir, this was the opinion over there. But in India, the Indian perspective, as antiplatelets remain the mainstay of the treatment and management of ACS. So, how older antiplatelets are better, or newer antiplatelets are better? So, how will you comment on that?
We also treat the patients in same way as you asked Ramesh about how we treat in India.
Right.
We also, I being in a tertiary center, we also try to, but the problem in US and India especially, in comparison to US, that majority of our patients come to us much late. Two registries, Kerala registry and the CREATE registry, all show that they come after 5 hours, but our practical experience is that they come much later also, say after 12 hours, 18 hours, 24 hours or even 48 hours. So, our problem is something separate than in US, because the awareness among the population that they have been able to make, we have failed to make because we alone doctors can do it. Right. As a STEMI Council convener, I have been trying with different secretaries. We had a recent meeting. Ramesh also attended that meeting, and 16 secretaries from different states came. And we are trying to improve the situation in our country. But apart from that, if the patient comes early, we go for primary PCI, or if the patient has already been thrombolized, we ask them to go for angiography and if required angioplasty. And we are promoting, we call it as pharmacoinvasive angioplasty, because a patient residing 200 kilometers from our metro cities, many of them don't have any cath labs. So, in order to come to a cath lab PCI capable hospital, as we call it, it will take another 5-6 hours time, and the patient is non-reperfused and the damage is done already. So, we thrombolize the patient, and we advocate from various societies, like not only from Cardiological Society of India, but also from API, Association of Physicians of India, and also Indian Medical Association. So, from different platforms, we had been advocating the doctors to thrombolize themselves, keep the patient for few hours, then to send within 2 to 24 hours as per the European guidelines, so that we can do a early coronary angiography, and we can, if there is a blockage more than 50% in the epicardial coronary arteries proximally, means left main, and if it is more than 70% in the other coronary arteries, then in that case we go for stent angioplasty in those group of patients. And regarding usage of the molecules, we depend more on clopidogrel. We load with 600 milligrams. We give a aspirin 350 milligrams soluble aspirin, and we give some heparin also 5000 units. as a rule in the in the ER, and within 60 minutes we take the patient to the cath lab as per the abroad. It is being done by Dr. Ramesh and other friends in US or in Europe. We do like that, but this facility is not present in all the setup. Just to give some data regarding the incidence of STEMI, the NIC 2017 data, it was also held in New Delhi in the same hotel. They showed that the total number of STEMI patients were 30 lakhs, and out of that only 40%, that is 12 lakh patient, had received thrombolysis, and only 56,000 patients, that is not even 2% of the total STEMI population, they got some sort of angioplasty. We do not know the nature, whether it was primary angioplasty as such or pharmaco-invasive angioplasty or rescue angioplasty which occurs after a failed thrombolysis. So, we do not have the details of those angioplasty, but it shows the incidence of primary angioplasty after a myocardial infarction in our country is as lower than 2%, whereas majority of the patient had thrombolysis, but it is very unfortunate and a dismal situation, so to tell, that 60% of the patient, or rather 58% of the patient were non-reperfused. I believe in certain states in US also the situation is like that, like the North Carolina data, somebody was presenting, some stalwart in this task force, he is also in the task force of US STEMI task force, and he was telling that 20% of the patients in USA also from different states, it is not uniform, some of the states they are not being thrombolized even. So, that being the situation, but in comparison, as you asked a comparative data, smaller European countries like Belgium, Netherlands, Scandinavian countries, France, Germany, and now in UK for the last 3-4 years after NHS has allowed doing primary angioplasty there, the incidence of primary angioplasty is much more, and they almost do in Japan also, out of 199 to 99.99% they go for primary angioplasty.
Right. So, sir, I was just asking how there are newer antiplatelets, and as antiplatelets are mainstay of the treatment in ACS, so how newer antiplatelets are better than the older ones, or what is the criteria to choose a particular antiplatelet agent?
Yes, Ramesh, you tell.
So, I mean, I think if cost is not a concern, the newer antiplatelet agents which are more potent should be the mainstay of therapy following these acute MI patients. In our center, obviously, we actually load them pre-angiogram with newer antiplatelet agents such as ticagrelor. So, one thing we have to understand here is it is nothing that it is a newer is always better, but in this scenario, we are trying to limit the amount of sticking of the platelets.
Right.
So, in a patient with a heart attack, you do not want the platelets to stick to each other in the arteries and cause more thrombosis. And the way to do that is if you give clopidogrel, the inhibition of platelet activity is about 40%.
Right.
Whereas if you give a ticagrelor, which is, as you are saying, new, we shouldn't consider it as any more new. It has been used for several years now.
Yes.
That actually can inhibit the platelet activity to 60 to 80%.
Right.
So, if cost is not a concern, everyone should get ticagrelor.
Right. So, thank you, sir. Apart from that, this newer agent, which is ticagrelor, has a reversible antiplatelet action. So, how this helps clinically or pharmacologically?
I mean, I think so. The benefit of a ticagrelor, which is more reversible, is that if you have given it and if the patient needs to go for surgery, you can stop it, and we check actually some of the platelet activity by a blood test, and we can take the patient for surgery if need be within 2 days or a day and a half or something like that.
Right.
So, it definitely reversibility matters as compared to another agent which is irreversible. You might have to wait for 5 to 7 days.
Right. So, another parameter which is variability. So, even it has got a good point that variability is not a concern in patients to patients. So, how that will help, and also the elimination is mostly in feces. So, is it really safe in renal patients also?
Yeah, it is safe in kidney patients. You highlighted a plus point of ticagrelor. So, like clopidogrel also, it can be used in kidney patients, because the kidney patients as a whole have more thrombogenicity, and especially as we have been discussing acute coronary syndrome, it is a thrombotic milieu. In that phase, whatever you give clots,
Right.
you give heparin in a conventional dose, you do the ACT, you find ACT is 170 seconds. We want 250 to 300 seconds.
Yes.
So, the milieu as a whole is thrombotic. So, in that milieu, it is better to use the stronger agents. Prasugrel we do not use, as Ramesh has rightly pointed out, that the half-life is much more, and it is stronger in action than ticagrelor. It has been shown recently as well in ISAR 5 trial from German Heart Center by Adnan Kasrati and his group, and it shows that prasugrel is little better, but we usually give prasugrel after passing the wear, not before the coronary angiogram.
Right.
Because though rarely, if a few patients also land for surgery, means they are not angioplastiable, they have got multiple lesions, diabetic, diffuse disease, smaller vessels, long lesions. In those cases, we cannot transfer the patient or refer the patient for surgery,
Right.
because prasugrel's action lasts much more, and you have to wait for long 7 days. And ticagrelor, as he has pointed out, has a shorter half-life, and you stop for 2 to 3 days, and you can go for any surgery, any major surgery after that.
Right.
So, it is not only stronger, but its action is reversible, and you can offset the action very soon, and switching over is also very smooth. You can smooth from other molecules to ticagrelor very easily, but it has got some side effects, like 20% of the patients in India we cannot use, because the patient tells of severe SOB. In patients with mild to moderate shortness of breath, we do not stop the molecule, but in case of severe cases, in about 10% of the total cases, we have to stop the molecule permanently. And second, in patients with bradycardia, or where there are sinus pauses or some sort of conduction problem, this precipitates the problem further. So, we cannot use this molecule in those small percentage of patients. So, these are like in inferior volume, many a times they are having bradycardia as low as 30-35 heart rate. So, we can do by putting a pacemaker, but if you do not want to put a pacemaker, it is better to avoid this molecule. But okay, we can use, as I told you, we can put a temporary wear and then we take it out next day.
Right.
So, that is the way we can use it, but it is much more effective, and the Plato trial have shown that it is the first antiplatelet agent which has not been shown by prasugrel as well, that in the Timitriton 38 trial it has some advantages, less than thrombosis, etc., but it showed, the Plato trial, that it reduces the mortality in comparison to clopidogrel in this group of patients with coronary artery syndrome. Significantly it reduces by 1.2%. So, these are some of the advantages of the molecule ticagrelor, and I think people all over the world, doctors, cardiologists, they are using ticagrelor more than clopidogrel. And another thing I forgot to tell, the incidence of drug resistance is much lower in comparison to clopidogrel.
Right.
Yes.
So, that is all about interpatient variability is really very less. So, sir, the last thing I would like to ask, many of the doctors are hesitant to use ticagrelor for the long term. So, what is your opinion on long term use with ticagrelor as a molecule?
So, absolutely. Now, with the Twilight study that was performed and presented recently at TCT and also at the AHA, another such study was performed. Instead of discontinuing the newer antiplatelet agent, it is probably better to stop aspirin and continue ticagrelor for long term.
Great.
For even probably lifelong. So, the recommendations now are changing and are going to change in the guidelines as well, that it is safer to stop aspirin and continuing ticagrelor for lifelong.
Great. Sir, what is your take on this?
Yeah, I totally agree with Dr. Ramesh, and actually we are part of Themis trial, which is an international trial done in Asian individuals.
Right.
The counterpart was Pegasus trial run abroad, and the Themis trial data was presented in the last European Society meeting in Munich, and they showed that actually we have conducted, and there were quite a few number of patients in that study. We recruited more than 100, I think, and it showed that you give for the first year, as Dr. Daggubati mentioned, that for 1 year 90 milligrams BID along with aspirin small dose, because they don't act well with a larger dose of aspirin.
Right.
And after 1 year you continue ticagrelor alone, but in a smaller dose, 60 milligrams BID. So the bleeding incidence is less and you get anti-ischemic effects equally good like 90 milligrams BID of ticagrelor. So it is proved by 2-3 trials, as he has mentioned. First one in the line was Pegasus trial done abroad. Themis trial recently concluded by us in India, and the data was presented in ESC and approved. And third one he mentioned about the Twilight trial, which are all similar trials, and where we have seen if we can continue ticagrelor for long term, the effects are better than aspirin alone or clopidogrel alone.
Wonderful, sir. I thank you for the wonderful insights that we have gained through this panel discussion, and I also hope the viewers or the fraternity who are viewing this video will definitely gain some good practicing day-to-day practicing insights. So I again thank you both for being a part of this channel. Thank you very much.
Thank you.
Thank you.